Hello everyone. Welcome to the Docsaab's diary again, and I am very pleased to guide you through this critical and comprehensive presentation on snakebite. We will dive deeply into its common venomous snakes, its clinical features, the essential investigations required for timely diagnosis, and most importantly, the evidence-based treatment strategies that save lives. This is just not an academic exercise. For many, especially in India, this knowledge can be the difference between life and death. Let's begin by acknowledging the immense and often underestimated challenge snakebite possesses. Globally, it is classified by the World Health Organization as a neglected tropical disease, but the statistics truly hit home when we look at India. Tragically, our nation bears the unfortunate distinction of having the highest snakebite mortality in the entire world. We are talking about an estimated 2.8 million cases annually, with a staggering 58,000 people die from snakebite envenoming each year in India. According to robust WHO estimates, this makes it a truly life-threatening and crucially a time-critical medical emergency. Every minute counts. Its prevalence is particularly high in rural agriculture areas, often peaking during the monsoon season when snakes are more active and human snake encounters increases. And while it's a national problem, its impact is disproportionately felt in specific regions. A sobering 70% of these devastating deaths occur in just 8 low altitude rural states like Bihar, Jharkhand, Madhya Pradesh, Odisha, Uttar Pradesh, Andhra Pradesh, Rajasthan, and Gujarat. Understanding this geographical concentration helps us target intervention efforts more effectively. In India, while many snake species exist, the vast majority of serious envenomation that require medical intervention and account for the high mortality are attributed to what we commonly refer to as the Big Four. These are the common cobra, primarily known for its potent neurotoxic venom, which affects the nervous system. Then the common krait, another significant neurotoxic snake, notorious for its nocturnal habits and often subtle bite marks. Then Russell's viper, a highly dangerous snake with a predominantly vasculotoxic venom causing significant bleeding and tissue damage. And finally, the saw scale viper, the smallest of the big four but incredibly potent, also possessing a powerful vasculotoxic venom. Each of these snakes inject a unique cocktail of toxins that produce a distinct clinical syndromes. Recognizing this pattern is absolutely fundamental for both diagnosis and targeted treatment. Let's now dive into the specific clinical features, starting with the neuroparalytic envenoming, which is typically caused by elapid snakes like the cobra and krait. The onset of symptoms varies. Cobra bites generally manifest within 30 minutes to 6 hours, while krait bites can be delayed, sometimes appearing up to 24 or even 36 hours post bite, making early diagnosis is challenging. The symptoms are primarily neurological, impacting muscle control, and can be easily remembered using the mnemonic, the 5Ds and 2Ps. The 5Ds include the dyspnea, difficulty breathing leading to eventual respiratory failure. Dysphonia means changes in voice, often becoming hoarse or weak. Then dysarthria means slurred or unclear speech due to muscle weakness. Then diplopia means double vision, indicating paralysis of eye muscles. Then dysphagia, that means difficulty swallowing, posing a serious aspiration risk. Then two piece included the ptosis, means drooping of eyelids, often the earliest and most noticeable sign. Then there is a paralysis, means general muscle weakness progressing to flaccid paralysis throughout the body. The progression is often sequential. You might first notice subtle forehead furrowing, followed by ptosis, then diplopia, then speech and swallowing difficulties, and ultimately life-threatening respiratory failure due to paralysis of the diaphragm and intercostal muscles. And other signs of impending respiratory failure are diminished or absent deep tendon reflexes and head leg, and additional features like stridor ataxia may be also seen. Also, associated hypertension and tachycardia may be present due to hypoxia. At the bedside, we can quickly assess respiratory function. In adults, a single breath count of less than 30 digits or breath holding time of less than 45 seconds are strong indicators of impending respiratory compromise. Similarly, the inability to complete a full sentence in one breath is a red flag. These rapid assessments are crucial for timely intervention. It's important to note that bilateral dilated pupils in elapid envenoming are not a sign of brain death. They are a treatable symptom. In this picture, you can see the forehead furrowing and ptosis and also the bilateral dilated pupils. Moving on to vasculotoxic envenoming, primarily caused by the viper species like the Russell's viper and saw scale viper. These venoms wreak havoc on the circulatory system and tissues, manifesting in both local and systemic effects. Locally, at the bite site, you will observe rapidly progressive swelling, often quite a painful and extensive, blistering, which can be filled with clear or hemorrhagic fluid, ecchymosis like bruising, and eventually necrosis, which can be severe and lead to permanent disability. Severe local pain, which, if accompanied by tightness and pallor, should immediately raise suspicion for compartment syndrome, a critical condition requiring urgent attention. Systemically, the key feature is uncontrolled bleeding due to venom-induced coagulopathy and capillary damage. You might see gum bleeding, a classic sign, then epistaxis, hematemesis, or a melena, and hematuria or a continuous bleeding from the bite site or any venipuncture sites. Acute abdominal tenderness may be suggest gastrointestinal or a retroperitoneal bleeding. Lateralizing neurological symptoms such as asymmetrical pupils may be indicative of intracranial bleeding. The most life-threatening systemic complication is acute kidney injury. Toxins directly damage kidney tubules, leading to symptoms like oliguria or even anuria, hematuria, and hemoglobinuria. This can quickly progress to renal failure requiring dialysis. Hypotension due to fluid loss into tissues or vasodilation often exacerbates AKI. Other features can include parotid swelling, conjunctival edema, and in severe cases, acute respiratory distress syndrome. The rapid identification of these signs is a paramount for a patient survival. In this image, you can see the gum bleeding, bleeding from the bite site, and there is some conjunctival hemorrhages. Continuing with the clinical features, painful progressing swelling is a crucial local indicator of significant envenoming, particularly seen with the Russell's viper, saw scale viper, and cobra bites. The swelling isn't just a cosmetic, it's a sign of venom actively causing localized inflammation, tissue destruction, and fluid extravasation. The affected limb becomes tense, shiny, and often develops a rancid smell like in necrotic areas. This swelling can lead to severe pain and, as mentioned, carries a high risk of compartment syndrome if not managed appropriately. Then we have a myotoxicity, which is prominent feature of sea snake bites. This involves direct damage to muscle tissues. Patient typically present with severe muscle pain and tenderness, generalized muscle swelling, involuntary muscle contractions or spasm. The characteristic passage of dark brown urine due to myoglobinuria. Myotoxicity can lead to serious complications such as acute kidney injury, hyperkalemia, high potassium levels from muscle breakdown, leading to dangerous cardiac arrhythmias, and even compartment syndrome if severe swelling occurs in confined to muscle compartments. While neuroparalytic signs are less common, subtle manifestation might also be observed in some cases. Lastly, a particularly challenging scenario is the occult snake bite. This refers to bites where the patient doesn't immediately recall being bitten or present with the non-specific symptoms, making diagnosis difficult. This is most commonly associated with the crate bites. Crates are primarily nocturnal, meaning bites often occur while the victim is asleep. Their fangs are small and slender, leaving very minimal, almost invisible bite marks. Consequently, victims frequently wake up in the early morning already experiencing paralysis but with no local pain or obvious bite site. The classic history for an occult crate bite involves a patient who went to sleep feeling healthy but then wake up with a severe, inexplicable epigastric or umbilical pain and vomiting. This pain can persist for hours, often leading to misdiagnosis as a gastroenteritis or other abdominal conditions. Only later do the characteristic neuroparalytic symptoms develop. Therefore, any unexplained respiratory distress or sudden onset of acute flaccid paralysis in children from endemic areas, especially with associated ptosis, should raise a very high suspicion for crate envenomation. Sometimes patient may even complain only of isolated throat or chest pain. Maintaining a high index of suspicion is a key to uncovering these hidden bites. Having understood the diverse clinical presentation, let's now outline the comprehensive management strategy largely guided by the WHO guidelines. This isn't a single intervention but a systemic, multifaceted approach. Our roadmap to recovery involves several critical sequential steps, including immediate appropriate first aid at the scene, rapid and safe transport to well equipped medical facility. Upon arrival, a prompt rapid primary clinical assessment combined with immediate resuscitation if needed. Then thorough investigations and laboratory tests to confirm envenoming and guide treatment. The timely administration of antivenom and the specific antidote. Extensive supportive and ancillary treatment to manage complications. Specific care for the bitten part. Crucial follow-up care post-discharge. And finally, comprehensive rehabilitation to restore function. The guiding principle throughout this entire process is paramount. Every intervention must be carefully considered for its benefit and potential risks. First aid is the initial crucial response administered immediately after the bite. Its primary aims are to slow venom absorption, preserve life, prevent complications, alleviate early distress, and most importantly, facilitate rapid transport to professional medical care. But remember, the golden rule here is aim to do no harm. Many traditional first aid methods are not only ineffective but actively dangerous. This is where the easy to remember mnemonic carry no right becomes your guide. Carry this means do not allow the victim to walk. Walking increases blood circulation, which increases venom spread. Immobilize them and carry them if possible. No means this is perhaps the most vital do not list. Absolutely no tourniquets, they can cause ischemia and gangrene, leading to limb loss. No electrotherapy, no cutting or incision at the bite site that increases infection risk and doesn't remove venom. No pressure immobilization unless specifically trained for certain neurotoxic bites and you have the correct equipment. And absolutely no sucking of venom It's ineffective and introduces bacteria. Most traditional remedies should be avoided. Then R is the reassure the patient. A calm patient is less likely to panic, and panic increases heart rate, which again increases the venom spread. Plus, remember that around 17% of all snake bites are from non-venomous species, so reassurance is often truly warranted. I is immobilize the limb, treat the bitten limb as if it were a fracture. Use bandages or strips of clothes to gently hold splints like sticks or rolled newspapers to prevent movement. Crucially, do not apply pressure or block blood supply. The goal here is to minimize muscle movement, which pumps venom through the lymphatic system. Then GH means get to the hospital immediately. This is a non-negotiable. Call emergency services like 102 or 108. Rapid transport is a key. While an ambulance with ventilator is ideal, do not delay for one if unavailable. A motorbike with a third person supporting the patient can be practical alternative in many rural settings. Time is tissue and time is life. T means tell the doctor any systemic symptoms that develop or progress on the way to the hospital, such as new onset of ptosis, increasing swelling, or dizziness. This valuable information helps guide immediate treatment upon arrival. Additionally, remove any constricting items like shoes, rings, watches, or tight clothing from the bitten area, as swelling can quickly turn them into dangerous tourniquets. And always leave blisters undisturbed to prevent infection. This is how you immobilize the limb for the transportation. Upon a patient's arrival at the hospital, whether they appear critical or seemingly stable, a rapid primary clinical assessment is a paramount. For a critical patient, we immediately launch into the ABCDE approach. A means airway is the clear. Is there any obstruction from swelling or secretions? B means breathing. Is the patient breathing adequately? Are there signs of respiratory distress or paralysis? Patients with respiratory muscle paralysis due to neurotoxic envenoming require immediate intubation and mechanical ventilation. C means circulation. Is the patient is in shock? Are they hypotensive? Assess pulse, blood pressure, and signs of perfusion. D means disability. Assess the neurological status. While the Glasgow Coma Scale might be affected by paralysis and not fully reliable, assess for ptosis, pupil size, and response to pain. E means exposure, environmental control. That means fully expose the patient to assess the bite site and any other injuries while preventing hypothermia. Patient should be intubated if possible or provided with airway support and ventilated with a resuscitation bag. However, the GCS scale cannot be used to assess the level of consciousness of patient paralyzed by neurotoxic venoms. Urgent resuscitation is indicated in specific life-threatening situations like profound hypotension and shock, terminal respiratory failure from neurotoxic envenoming, sudden clinical deterioration after releasing a tight tourniquet, which can release a bolus of venom, or a cardiac arrest obtained from hyperkalemia due to severe muscle breakdown. For a vasculotoxic patient with a severe bleeding, shock, or rapidly declining urine output, immediate ICU care is necessary for aggressive volume replacement, vasopressors, dialysis if needed, and in timely administration of blood products. For a neuroparalytic patients with respiratory paralysis, urgent ventilator management and intubation are life-saving. Early identification of these critical signs allows for immediate life-sustaining interventions. Continuous and vigilant monitoring is an absolute cornerstone of snakebite management. We rigorously track vital signs, pulse rate, respiratory rate, and blood pressure. But crucially, we frequently perform the 20-minute whole blood clotting test, 20 WBCT, initially every hour for the first 3 hours, then every 4 hours for the next 24 hours, and then as clinically indicated. This test is vital for guiding antivenom therapy. We also meticulously monitor distal pulses and capillary refill, constantly vigilant for the development of compartment syndrome. This is a serious condition where swelling within a closed muscle compartment, like in the lower leg or forearm, compresses nerves and blood vessels, potentially leading to irreversible tissue damage. Clues include disproportionate pain, pain on passive movement of the digits, or pallor, a pulseless limb, and numbness. If compartment syndrome is suspected, direct measurement of intra-compartment pressure is critical. This is done by inserting a 16 gauge IV cannula into the affected compartment and connecting it to a manometer. A diagnosis is established if the pressure is above 40 centimeter of water or a saline. It's vital to remember that fasciotomy, a surgical incision to relieve pressure, should only be performed if the measured pressure is definitely high and any underlying coagulopathy has been corrected. Compartment syndrome is relatively rare in snakebite victims, and unnecessary fasciotomy without correcting bleeding abnormalities can paradoxically lead to fatal hemorrhages. Let's talk about the investigations. The 20-minute whole blood clotting test, or a 20 WBCT, is arguably the most reliable and accessible bedside test for assessing coagulation status in snakebite patients. It's a simple yet powerful diagnostic tool, especially in resource limited settings. Here's, here's the straightforward procedure. Obtain a few milliliters of fresh venous blood from the patient. Carefully place this blood into a new, clean, and dry glass tube or vessel. It is crucial that the tube is absolutely clean and dry, as any residue or moisture can interfere with the clotting. Leave the tube undisturbed at ambient room temperature for precisely 20 minutes. Do not agitate it. After 20 minutes, gently tilt the tube once. Do not shake it. Interpreting the results, if the blood is solid and has form of firm clot that hold its shape when tilted, the patient has passed the test. This generally indicates normal coagulation, and ASV is typically not required at that specific moment. However, if the blood remains entirely liquid, or if it forms only a partial flimsy clot that disintegrates when tilted, it indicates significant coagulopathy. In this scenario, ASV is clearly indicated. This test is performed repeatedly every hour initially, then every 6 hours to monitor the progression of envenoming and the effectiveness of ASV, guiding subsequent doses. While the 20 WBCT is invaluable, other investigations provide a more complete picture of the patient's condition and help manage complications. General blood tests like complete hemogram, liver function test, renal function test, and blood sugar levels are essential to assess overall organ function and potential damage. More sophisticated labs can perform bleeding time, clotting time, prothrombin time, activated partial thromboplastin time, serum fibrinogen, and D-dimer assay. These provide a detailed insight into the clotting cascade. Urgent warning, it's absolutely crucial to remember that arterial puncture is strongly contraindicated in patients with known or suspected hemostatic abnormalities due to the significant risk of uncontrolled bleeding. Myotoxicity markers. For suspected myotoxicity, we measure CPK, HGOT, and urine myoglobin. Cardiotoxicity markers for cardiac involvement, CPKMB, 2D echocardiography, and BNP can be helpful. Imaging like ECG help assess cardiac rhythm and function, and abdominal ultrasound can identify signs of internal bleeding or kidney damage. Urine analysis, frequent urine microscopy for red blood cell, cast, and protein is important for ongoing renal assessment. This investigation, along with arterial blood gases, are repeated frequently during the acute phase to monitor the progression of systemic toxicity and guide ongoing management. Now we come to the most critical therapeutic intervention, the anti-snake venom or ASV. This is the only specific antidote available for snake envenoming and it's truly life-saving. So what exactly is ASV? It's a typically an enzyme refined Fab2 fragment of immunoglobulin G meticulously purified from the serum or plasma of horses or sheep. These animals are immunized with specific snake venoms, stimulating their immune systems to produce antibodies. These antibodies are then harvested and proceed to create the ASV. The primary function of ASV is to neutralize free, unbound venom circulating in the bloodstream. It works by binding to venom components, rendering them harmless, and to some extent, it can even dissociate some toxins that are already bound to target tissues. The World Health Organization has recognized its undeniable importance by including ASV in its list of essential medicines. In India, we predominantly use polyvalent ASV. This means it contains antibodies effective against the venoms of all four of our big four species: the Russell viper, common cobra, common krait, and saw scale viper. ESV is available in both liquid and lyophilized forms, with the lyophilized version offering a longer shelf life, fewer cold chain requirements, making it more practical for remote areas. While ASV is life saving, its administration requires strict adherence to critical principles. There are crucial do's and don'ts. Firstly, the indications. ASV is administered only when there are clear signs and symptoms of envenomation confirmed clinically and ideally by laboratory test like the 20-minute whole blood clotting test. A crucial point. There are no absolute contraindication to ASV in truly envenom patients. This means that if patient is clearly suffering from snakebite poisoning, the potential benefits of ASV far outweigh the risk of allergic reactions. However, we must not administer ASV routinely to every patient who claims to have bitten if there are no signs of envenoming. This unnecessarily exposes patient to risk and wastes a precious resource. Crucial don'ts. Never give an incomplete dose. An insufficient dose can be ineffective and potentially sensitize the patient to future reactions without providing full benefit. Purely local swelling without rapid progression or systemic signs is not an indication for ASV. Swelling that developed hours ago and isn't actively worsening also doesn't warrant ASV. Rapidly progressing swelling, however, does. The ASV dosing regimen differs based on the type of envenoming, reflecting the different venom actions. So each ml of ASV neutralizes 0.60 mg of Indian cobra venom and Russell's viper venom, and 0.45 mg of common krait venom and saw scale viper venom. ASV should always be administered by the intravenous route, never intramuscularly or locally. It should be given slowly, ideally diluted in normal saline or 5% dextrose over an appropriate infusion time. The physician should be at the bedside during the initial phase of the infusion to monitor for reactions. ASV must never be given by the intramuscular route. IM administration leads to poor absorption, delay onset of action, and increase the risk of local complications and allergic reactions. Do not inject ASV locally at the bite site. This is ineffective, causes extreme pain, and can dangerously increase intracompartmental pressure, worsening local tissue damage. Finally, always maintain strict aseptic precautions during preparation and administration to prevent pyrogenic reactions. And perhaps most importantly, always have epinephrine, means the adrenaline, drawn up and ready at the bedside before ASV administration to promptly manage any potential allergic reactions. Preparedness is a key. For a neuroparalytic snake bite, means cobras or kraits, the recommended initial dose is 10 vials state immediately as an infusion over approximately 30 minutes to 1 hour. The patient is then reassessed after 1 hour. If there is no clinical improvement, means ptosis is unchanged or worsening or respiratory distress persists, a second dose of 10 vials can be administered. Generally, no more than 10 vials are needed for neurotoxic bites, as the effect is often seen within these initial doses. For vasculotoxic snake bite, means Russell viper or saw scale viper, two main regimens are widely used. First is the low dose infusion therapy. This is often preferred due to its efficacy and ASV conservation. It involves 10 vials for Russell Viper or 6 vials for Saw scale Viper, state as an infusion over 30 minutes to 1 hour. This is then followed by 2 vials every 6 hours as an infusion in 100 ml of normal saline. These continue until the 20-minute whole blood clotting test normalizes or for a maximum of 3 days, whichever comes first. High dose intermittent bolus therapy. This involves 10 vials. 10 vials state over 30 minutes to 1 hour, followed by 6 vials every 6 hours as a bolus infusion until the 20-minute whole blood clotting test normalizes or local swelling significantly subsides. It's a critical point that with the currently available polyvalent ASV in India, no ASV is available for needed for sea snake bite or pit viper bites, as our polyvalent ASV does not contain antibodies against their specific venoms. While standard dosing applies to most cases, there are specific scenarios that require adjustment to our ASV strategy. One crucial exception is when a patient requires life-saving surgery, particularly for an intracranial bleed caused by a severe vasculotoxic envenoming. In such critical situation, a rapid reversal of coagulopathy is paramount before surgery can be proceeded. Here, a much larger initial bolus of ASV, typically up to 30 vials, can be administered over 1 hour. This aggressive approach aims to restore coagulation as quickly as possible to enable necessary surgical intervention. Due to the large protein volume, meticulous observation for adverse reaction is essential during this rapid infusion. Another common scenario involves victims arriving late to the hospital, sometimes several days post-bite, often already suffering from complications like the acute kidney injury. In these cases, our first step is to assess for ongoing venom activity, specifically ongoing bleeding. We perform the 20-minute whole blood clotting test. If the 20 WBCT is abnormal, then ASV is still indicated and should be administered according to the vasculotoxic regimen. However, if the 20 WBCT is normal, meaning the coagulopathy has resolved spontaneously or the venom has been cleared, then ASV is no longer needed. The focus then shifts entirely to managing the established complications such as the acute kidney injury with supportive therapies like the dialysis. Two special populations often raise questions regarding ASV dosing: children and pregnant women. It's vital to clarify this point as misconception can lead to suboptimal treatment. Firstly, for children, this is a critical point that is often misunderstood. Children receive exactly the same dose of ASV as adults. This is not scaled by weight. The rationale is simple. A venomous snake injects the same amount of venom into a child as it does into the adult. The child having a smaller body mass may experience the effects more rapidly or severely, but the amount of venom to be neutralized remains constant. The ASV can be diluted in 5 to 10 ml per kg body weight of normal saline, but the ensure the total fluid volume doesn't lead to fluid overload. Reduce the total diluent volume to 200 ml if necessary. Secondly, for pregnant women, while limited large-scale studies exist, current evidence overwhelmingly indicates that ASV is safe in pregnancy. There is common but often unsubstantiated belief that snakebite invariably leads to spontaneous abortion. In reality, studies show that while some cases do result in miscarriages, many do not. In an envenom pregnant victim, ASV should be given in the same dose and under the same criteria as any other standard patient. Good maternal and fetal outcomes are significantly enhanced when ASV is administered promptly. These cases, especially if bleeding is present, should ideally involve obstetric consultation. While ASV is life-saving, it's a heterologous protein and can unfortunately cause adverse reaction. These reactions fall into three main categories based on their onset. Early anaphylactic reactions. These are immediate hypersensitivity reactions occurring rapidly within minutes to 3 hours of ASV administration. Symptoms can range from mild like urticaria, itching, wheezing to severe like angioedema, bronchospasm, hypotension, anaphylactic shock. Second is the pyrogenic reactions. These typically occur within 1 to 2 hours and are characterized by fever, chills, rigors, and nausea. They are obtained due to pyrogens in the preparation or rapid infusion rate. Then last is the late reaction. It's also called serum sickness type. These are delay hypersensitivity reactions manifesting 1 to 12 days after ASV administration, most commonly around day 7. Symptoms include fever, rash, joint pain, and swelling. For a prophylaxis, some protocols recommended pre-medication with the subcutaneous adrenaline or a hydrocortisone with the chlorpheniramine, although opinions is the vary. Crucially, a test dose of ASV is not recommended. It's unreliable for predicting a full-blown reaction and wastes valuable time. Treatment for early anaphylactic and pyrogenic reaction is immediate and critical. The first and most important intervention is epinephrine. For adults, this is 0.5 mg administered intramuscularly into the deltoid or anterolateral thigh. For children, it's a zero point zero 0.01 mg per kg body weight. Repeat every 5 to 10 minutes if symptoms persist. Concurrently, promethazine HCl 25 mg IM or chlorpheniramine maleate 10 mg IV can be given, along with hydrocortisone 100 mg IV for anti-inflammatory effects. For a bronchospasm, inhaled beta-2 agonist like salbutamol can be helpful. Prompt recognition and aggressive management of this reaction are key to preventing morbidity and mortality. Let's visit the role of atropine and neostigmine, crucial for refining the management of neurotoxic envenomation. Neostigmine is an anticholinesterase medication. Its mechanism of action involves inhibiting the enzyme acetylcholinesterase, which normally breaks down acetylcholine at the neuromuscular junction. By inhibiting this enzyme, neostigmine prolongs the presence of acetylcholine, effectively enhancing neuromuscular transmission. These can help reverse respiratory failure and other neurotoxic symptoms, particularly those caused by postsynaptic neurotoxins like those in cobra venom. The typical dosage for adult is 0.6 mg of atropine to counteract the muscarinic side effects of neostigmine like bradycardia and excessive secretions, followed by immediately by 1.5 mg of neostigmine IV state. For children, the dose is scale 0.05 mg per kg atropine followed by 0.04 mg per kg neostigmine. This combination, 0.5 mg neostigmine with atropine for adults or 0.01 mg per kg for children, is then repeated every 30 minutes for maximum of 5 doses. We monitor the patient closely for positive response, typically measured by 50% or more recovery of ptosis within 1 hour of the initial dose. If there is no clinical response after the third dose, the atropine neostigmine infusion should generally be stopped as further doses are unlikely to be effective. For crate bites specifically, the ptosis is obtained due to presynaptic blockage, which unfortunately cannot be reversed by further ASV or excessive neostigmine. Natural regeneration of the nerve endings is required, which can take 4 to 5 days. Both ASV and atropine neostigmine injection should be considered for cessation once the initial pharyngeal muscle palsy syndrome resolves. Beyond ASV and specific antidotes, comprehensive supportive care is absolutely paramount in managing the complications that can arise from severe envenoming. This involves a range of critical interventions. Like mechanical ventilation, this is a life sustaining for patients experiencing respiratory failure due to neurotoxic paralysis, blood products for significant bleeding due to coagulopathy. FFP provides clotting factors and cryoprecipitate provides fibrinogen and factor 8. Inotropic support medications like dopamine or norepinephrine are used to maintain blood pressure and organ perfusion in patients suffering from shock. Hemodialysis essential for managing acute kidney injury, which can be severe and life-threatening complication of vasculotoxic envenoming. Fasciotomy, as discussed, this surgical procedure to relieve pressure in muscle compartment is a last resort, only performed after confirmed compartment syndrome via pressure measurement and only after any underlying coagulopathy has fully corrected. Surgical debridement, necessary for necrotic tissue at the bite site to prevent infection and promote healing. These may involve skin grafting in severe cases. These interventions often mean the difference between life and death and play a crucial role in preventing long-term disability. Our responsibility doesn't end with the acute management. Follow-up and rehabilitation are crucial for ensuring a complete and sustained recovery, preventing long-term disability and psychological distress. Upon discharge, patients and their families must be thoroughly educated. They need to be advised to return immediately if any new or worsening symptoms develop, such as new bleeding, increased pain or swelling, difficulty breathing, altered mental status, or any signs of systemic illness. It also vital to educate them about serum sickness, a common late reaction to ASV. These can manifest 5 to 10 days after treatment with symptoms like fever, skin rashes, and joint pain and swelling. This typically manageable with antihistamines and corticosteroids but needs to be recognized. For patients who have suffered severe local envenoming, rehabilitation begins even in the hospital. The affected limb should be maintained in a functional position. For example, a simple back slap can prevent foot drop or equinus deformity of the ankle. Venom can cause persistent stiffness, significant tissue loss, dermonecrosis requiring skin grafting, and even gangrene that may necessitate debridement or amputation. Restoration of normal function should commence with gentle, simple exercises. While supervised physiotherapy is ideal, relatives can be instructed on a schedule of activities. Conventional physiotherapy and occupational therapy play a significant role in accelerating functional recovery and improving quality of life post snake bite. It's a multidisciplinary effort. In conclusion, managing snake bite is a complex but ultimately rewarding challenge. It demands not just a medical expertise but also rapid decision making, a high index of suspicion, and compassionate care. Let's review the key takeaways. Avoid harmful first aid. Education on appropriate first aid is a paramount. Improper intervention can worsen outcomes. ASV is a life saving. Timely and correct administration of anti snake venom is the cornerstone of treatment. Vigilant monitoring is essential. Continuous assessment and management of complications are crucial for recovery. By applying these principles, we can significantly reduce the devastating impact of snakebite. Okay, guys, that's all from my side, and thank you for your attention and engagement today. And I hope this detailed presentation has given you more valuable knowledge and renew your commitment to tackling this significant public health issue. I encourage you to continue learning and to share this vital information. And for more educational content and updates, please consider liking, sharing, and subscribing to the Docsaab's Diary on YouTube and also on Instagram. Your support helped me to reach more people with crucial medical knowledge. And please feel free to reach out with any questions via comments. Thank you so much.